Thought y'all might like a little walk-up music for this presentation, just in case. So now we're going to lean into infectious disease processes and basically pneumonia. And then we will eventually touch on environmental occupational issues as well as cancer neoplasms. So let's get into this. So obviously we're talking about pneumonia when it comes to cancer, to infection with the respiratory system. And when it comes to pneumonia, we have a very high level but important designation that we use when we talk about pneumonia, not just as nurses, but as clinicians, period. So mid-level providers will view it in this way, as well as physicians and even administrators. The distinction here is community-acquired versus hospital-acquired pneumonias. So these definitions are as simple as they sound. They're pneumonias that are acquired in the community. They're versus infections that are acquired out or in a facility in the hospital. Now, all community and hospital-acquired pneumonias can be of any of these origins. They could be fungal, bacterial, histoplasmosis, toxoplasmosis, anthrax, viral, mycobacterium, aspiration pneumonia. All those things can happen both in a community and in a hospital. But the designation is important simply because it assists with one of the major principles with pneumonia, and that is containment or mitigation of the spread of pneumonia. There are some pneumonias that are highly infectious and highly contagious in that the initial symptoms are subtle or perhaps even not discerned during the period in which the individual is infectious or contagious. And in that case, if those patients are in the community, there's a different approach to how we manage containment. In the hospital, we may see symptoms of pneumonia pretty quickly relative to when the patient actually acquires the infection. In fact, we may know the source. Of ventilator-associated pneumonia is a great example of one in which we intubate a patient. They didn't have pneumonia. They develop it while they're on the ventilator, and we recognize it as it evolves. So for those reasons, these distinctions are important. We will discuss elements of bacterial, viral, fungal pneumonias and that sort of thing. The important thing to take away here is when you have a patient who acquires a pneumonia, such as tuberculosis, or as you guys know from living through it, COVID-19, and this occurs out in the community, then there is a process by which we do what's called contact tracing. So we track down all of the people that individual's been in contact with. This is crucially important still with tuberculosis. It's less of an issue now with COVID-19, as COVID-19, that strain of coronavirus has become endemic. We'll talk some about what that means in a minute, but those strains are endemic now, which basically means that contact tracing is a moot point at this point because it's so prevalent in our culture. But TB is another matter and needs containment. Now, that's pneumonia. We've already introduced the notion of empyema, and empyema and lung abscess are closely related. Now, empyema, as you recall from previous lectures, refers to fluid that's accumulated in the pleural space between the visceral and parietal pleura around the lung that has some type of, in this case, we care about an infectious type component associated with it. And that fluid is thick and viscous and generally not capable of draining, although sometimes you can get some that can drain some of that purulent fluid with a big enough chest tube. So in that case, basically you have what started perhaps as a pleural effusion. You have fluid in that space, and over time infection has evolved in that space, and it could be introduced from outside the body, or it could be normal flora that has just found a nice, warm, moist place in order to harbor, in which to harbor and colonize. So that would be an empyema. Now, an empyema can evolve into a lung abscess where you have just a really profound, prolific growth of bacteria in that empyema space, in that pleural space. But a lung abscess is not limited to the pleural space. So you could have a lung abscess evolve within the tissue itself or within the alveoli. So there's plenty of places where the lung could develop an abscess, and in that case, we have to treat it accordingly, and we will discuss that as we go further. Now, remember, I want to call back to, in earlier lectures, we discussed the thin alveolar capillary membrane that separates basically the human organism from the outside world. So the inside portion of the human from the outside world is separated by this thin alveolar capillary membrane. Now, whatever is going to move into the body obviously has to move through the airway down into the alveoli in order to get there. But the key is that we need this thin membrane for optimal diffusion of gases, both carbon dioxide and oxygen, across that membrane so we can oxygenate and so that we ventilate appropriately. So as you can imagine, if you recall, that alveolar capillary membrane is thinner than basically the thickness of a red blood cell. It's a very thin membrane. It's specifically designed to be thin to allow this diffusion to take place. In the context of pneumonia, then when we place bacteria in the presence of this thin alveolar capillary membrane, it can, one, provide an obstacle or an inhibition to that oxygen diffusion, air exchange, those gas exchanges. And because the tissue is not thick and dense, like a muscle, for example, it could easily be damaged by bacterial, fungal, or viral mediation. So we have to be attentive and appreciative of what that means. It doesn't mean we're a ticking time bomb waiting to explode. I'm trying to underscore the importance of that thin membrane and its fragility. Now, also a consideration here is that the alveoli, any portion of the neighborhood of the lung tissue, so the alveoli, the pleura, all of that area is immediately in the presence of and has access to a rich supply of blood and oxygen, as well as a nice, warm, moist environment. And all of those things together are a really wonderful growth media for any kind of virus, or, well, a variety, I should say, kinds of virus, fungus, mycobacterium, bacteria, etc. So we just have to be mindful that the pulmonary environment is rife for the potential for infection. Now, another issue that we want to consider here is inflammation of that parenchymal tissue. So when I say parenchyma, I've used that word a few times. I'm referring to the lung tissue in general. So I'm referring to the alveoli, the structures thereof, the bronchi, the terminal bronchioles, the vascularity, all of the tissues that surround the lung. That's what I mean by parenchyma, are associated in the presence of pneumonia, or associated with filling by an exudative process. So the first thing you think of when you think of pneumonia is you think about someone who has fluid in the lung, and that fluid is essentially a result of or facilitated an infectious process. And exudate here, remember, exudate refers to this fluid that has basically portions of basically debris from the breakdown of different cellular structures within the alveoli. It has the presence of the actual bacterium and byproducts of the presence of that bacterium and the body's defenses in attempting to assault and destroy that infectious process. So you've got white blood cells in there, you've got dead white blood cells, you've got other tissues that have been destroyed. So that produces this exudative process. So that that accumulation in time could cause and result in necrosis of the lung tissue, where you actually get death of lung tissue. And there you have the evolution of ultimately perhaps an abscess. So all of those things, you can see how this can evolve one thing into the other, kind of a domino effect, if you will, to kind of determine, to kind of grow an evolution of severity here. So as you might imagine, because of this thin alveolar capillary membrane and our dependence on that for gas exchange, you can imagine where pneumonia by itself is a major concern, major challenge. However, most commonly, patients have concomitant issues, concurrent issues with the pneumonia, and every problem you add to pneumonia makes the morbidity and mortality increase dramatically with each step. So if you have pneumonia and heart disease, then you have a potential strain of pneumonia to cause a heart attack. If you have a pneumonia and chronic kidney disease, there's the potential, or acute kidney injury, there's the potential for that kidney injury to evolve into chronic kidney injury. If you develop pneumonia with chronic kidney injury, there's the potential for worsening of that chronic kidney disease and ultimately ending up on dialysis. If you have one of the hormonal disorders, such as Addison's or Cushing's, the condition and or the treatment of those conditions can make you susceptible to the pneumonia, but also in the presence of the pneumonia make you susceptible to other concurrent infections and other organ system injuries. So as we add those, it increases the complexity. This slide is not for you to remember, it's for you to just have a familiarity. So you can see basically the criteria for community-acquired pneumonia means it happened, that we're pretty solidly sure that the patient acquired this outside the hospital less than or equal to 48 hours after it, and it's manifested less than or equal to 48 hours after admission. Now, a hospital-acquired pneumonia, you can see there are a lot of qualifying factors because things can present in various ways. Patients end up in the hospital, and then we find out at a certain point after their hospitalization that they've actually had this or developed this in the hospital. We want to be sure that we distinguish this correctly for a variety of reasons. And so you can see here hospitalization for greater than 2 days, like mentioned above, in an acute care facility within 90 days of the infection. If they lived in a nursing home or some type of long-term care facility, that's also considered hospital-acquired pneumonia if that's where their residence is and they developed it. So you can see the other criteria here, and as at the very bottom, you'll see something that will come up later in adult 3 when we start talking about ventilated patients, ventilator-associated pneumonia, that is most obviously a hospital-acquired pneumonia, because people usually, it's uncommon for patients to live on ventilators. However, there are some patients who live outside the hospital on a ventilator, yet those patients if they're on a chronic home vent, then they're at some sort of long-term care facility. So you can see how that kind of connects back in to the upper criteria. Again, don't want you to memorize that. I want you to see the distinction. So healthcare-related pneumonias are basically, as you can see from the definitions there, we're associating this pneumonia with acquisition in a hospital or healthcare type of environment. And ventilator-associated pneumonia tops the charts. That makes sense if you think about it, because when we place someone on a ventilator, we're taking a foreign object, an ET tube, we're inserting that object in their oral airway or nasal airway and advancing it into their trachea, down into the lower respiratory regions and creating basically a pathway for bacteria to migrate. When a patient is intubated, we're bypassing some of their normal protective mechanisms that help prevent pneumonias, namely the epiglottis and cough and sneeze reflexes. So those three things help us avoid a great number of lung infections. And we're bypassing all that when we put a plastic tube down their throat. And we're creating a passageway for bacteria to migrate from the oral nasopharynx down the trachea, down the tube, around the cuff, and potentially into the lungs. So you can see why that might be a chart topper for hospital-acquired pneumonias. Most commonly, hospital-acquired pneumonias are opportunistic in origin. In other words, these bacteria normally live in balance in our bodies, but they take this opportunity either because the patient is immunosuppressed, or just because they're weakened, or they have a new avenue, such as an ET tube, into the airway. So commonly, normal flora is responsible for hospital-associated pneumonias. That is, and it can vary on what that flora is. Staph aureus, for example, is a common culprit. It lives in the nasal passages. That could easily be something that could make its way into the lungs from the naso or oral pharynx. Pseudomonas is present in lots of places. Pseudomonas is in dirt. So it's easy to pick that up from feet, hands. This is one of the things we're concerned about with flowers, cut flowers, because they grow in the dirt, and there's not a way you can sterilize them before you place them in the hospital. Clostridium difficile, also another bacteria that can be present in the body and take the opportunity of a weakened immune system or out of balance normal flora in the gastrointestinal tract and use that opportunity to migrate. Clostridium difficile, as well as Acinetobacter, can live on surfaces much longer than some other bacterias. So these different infectious agents can migrate through just from bed rails to the patient, just simply being in the room, having gloves on, doing all the right things. But since it's alive on a bed rail, it can make its way to the patient. So, and then of course, any bacteria that can be transmitted by healthcare providers. This is the reason for PPE. This is our version of containment in attempting to contain one patient's bacteria from another. That's one. And then also an attempt to prevent us transmitting that patient's bacteria to them in an area that can make them more susceptible to infection. So that's why we care a lot about masks and gowns and gloves and hand washing and determining whether we should be using soap or a hand sanitizer during different things we do with patients. Commonly, hospital-acquired pneumonias are multi-drug resistant. So I've listed a few here: MRSA, VRE, and VRSA. This stands for methicillin-resistant Staph aureus, vancomycin-resistant Enterococcus, and vancomycin-resistant Staph aureus. These hospital-acquired pneumonias such as these are not commonly transmitted in the community. It's not often that someone catches MRSA from someone at home and develops a pneumonia as a result. And not to say it can't happen, but it's not common. Other viral infections are more common as far as community-acquired pneumonias. We'll talk about that later. But these bacteria, because they occur in environments where antibiotics are used quite a bit, they manifest, we see resistant strains. So methicillin-resistant Staph aureus has been around a long time. It's entirely possible that I may have a Staph aureus strain in my body that is methicillin-resistant. It's entirely likely. I've never had that manifest in any way or had a reason to test it. But my Staph aureus that's normal flora for me has had the opportunity over many years of nursing work to be exposed to other bacteria that have the genetic mutation to have a resistance to methicillin. So what happens here is anytime that bacteria becomes adjacent, comes in close proximity, and can commingle with a strain that is not resistant, then the resistant strain can, as you can imagine, like with breeding animals, you can pass DNA along from one species from, if you combine two species, you can get a mixed breed. Similarly here, when these bacteria come together and their DNA interacts, the non-resistant Staph aureus can acquire the genes necessary to become resistant to Staph aureus. So it's entirely possible you could have it and never have symptoms until, of course, you get immune compromised or develop a pneumonia or something like that. The same is true with vancomycin-resistant Enterococcus as well as vancomycin-resistant Staph aureus. They've just become acclimated to those antibiotics for exposure. And when that happens, this is what we mean by multi-drug resistant. So vancomycin-resistant Staph aureus, for example, is most commonly also methicillin resistant, which means we have to approach the treatment of that particular infection in a very different way than we would if we just had a Staph aureus pneumonia. Now, community-acquired pneumonias, common ones, I've listed some here. Staphylococcal pneumonia, well, staph and strep, but streptococcal pneumonias. There's multiple strains of this bacteria out there endemic in our culture. And what I mean by endemic is that it's just present in our population, in the human population, and you may not necessarily know when you contract it or encounter it. It's just present at all times, and it doesn't always cause issues, but there are times when it does. There are multiple strains of the streptococcal pneumonia. That's why there are pneumovaxes that help address some of those. Haemophilus influenza. There are A through F strains, and these can also be normal flora in the human body. They are invasive species of bacteria, so not to be confused with viral pneumonias that are like the flu virus. So influenza is a bacteria, Haemophilus influenza, bacterial infection, not the flu vaccine, flu virus. But it is invasive, and as you can see, it mutates into various strains. We have 6 of those out there these days. Legionella is another bacteria that can live in water that's not been properly filtered, or it's not flowing, stagnated, and that can be transmitted by consuming water. It's called Legionella because there was a group called the Legionnaires, and at one of their conventions there was an issue with the water, and this particular bacteria was pretty prevalent to create this pneumonia for this population of people. And when they isolated it, they named it after the Legionnaires there. Mycoplasma pneumonia is, so what I'm trying to convey here is how these things are transmitted. Legionella transmitted in water, Mycoplasma pneumonia transmitted person to person through airborne transmission. Viral pneumonias also person to person. As you well know, you catch the flu, which is a virus, you catch COVID-19, which is a virus, you catch it from someone. The common cold virus, commonly coronavirus, is you catch the cold from somebody who had the cold. And COVID-19 is essentially a mutation of the common cold into a more virulent viral type of infectious agent. Pneumocystis pneumonia, this is a fungal pneumonia. So I've got some fungal pneumonias listed underneath there. Pneumocystis, aspergillosis, blastomycosis, candida, histoplasmosis. These are all various iterations on fungal pneumonias. And I guess it's entirely possible that things could be spread person to person, but usually not. These are, the fungal pneumonias are pneumonias that take commonly an opportunity when someone is immune compromised or weakened in some way. Tuberculosis, you've probably heard of tuberculosis before. It is also spread person to person. It is highly infectious. It doesn't, by highly infectious, what I mean is that it can be passed easily from person to person. Just because it's highly infectious doesn't mean that it's going to create symptoms in everyone. This is why we do the TB testing that we do as a part of our program to identify exposure. People can be exposed and develop a response to tuberculosis, which means it has invaded this person's body and the body has responded, but doesn't mean the person necessarily became sick from it. So that's the distinction I'm trying to make here. It's very transmittable. Maybe that's perhaps a better way to say it. It's very transmittable, but it doesn't necessarily mean everyone is going to develop pneumonia from it. But we want to contain it as best we can, because you can acquire it and it can remain dormant for a very, very long time, years, and manifest in another time, and then of course be contagious and spread again. So it's easy for this to create an outbreak if we're not careful. And Pseudomonas, as I mentioned before, lives out in our environment. It lives on surfaces, it lives in the dirt. There were just a variety of places where Pseudomonas can be from which it can be contracted. So as a part of our assessment for pneumonia, of course, we're going to be assessing the respiratory system. And a common assessment finding is going to be dyspnea or tachypnea. And the patient's not going to say, I'm feeling dyspneic and I can see that I'm tachypnic. Patients are going to walk in and say, I can't breathe, or I'm having trouble breathing. I'm more short of breath than usual. They may also say, well, notice I also have a fever. So shortness of breath, fever, and chills are the common things that people will come in and present and say, this is why I'm at the hospital, and this is why I'm concerned. They often will have a cough. In fact, more times than not, the productivity of that cough varies from individual to individual, and of course the stage of the infection and the prevalence and the profound nature of mucus production at this point in time, and the efficacy of their cough effort. So those things are commonly associated. Now on exam, when we're examining them, we may find an elevated temperature. Vital signs can be otherwise stable. As far as heart rate, blood pressure, you might see an elevation in heart rate. You might see an elevation in blood pressure. Those things can be associated symptoms, not always. You may see sometimes a drop in blood pressure, depending on how severe the infection is and if it's moving into a more systemic type of manifestation. When we examine them with stethoscope, we expect that we're going to hear some form of fluid sounds in the lungs. What I mean by that is crackles, rales, or rhonchi. And as the fluid accumulates and moves into larger vessels or structures, not vessels, airways or structures, then they become deeper and louder. Small accumulation would result in crackles. As it progresses, it evolves into a more raucous and coarse sounding rattle. Wheezes sometimes associated with the infection. As you can imagine, in the infectious process, there is an inflammatory component to that. So as a patient perhaps develops inflammation, if there's inflammation of the airways that causes narrowing of the airways combined with the increased mucus production, they can have wheezes. And I've already mentioned the productive cough. Mental status changes is something that shows up sometimes. In fact, I think I've alluded to this with dehydration, particularly in the elderly population, the older population. Mental status changes are early warning signs of conditions like dehydration, hypo and hypernatremia, sepsis, urinary tract infection, pneumonia. All of these conditions, mental status changes, mom or dad just being a bubble off plum, just being not quite their normal self, can be an early warning sign, an early symptom. And often it's subtle enough at the beginning that the individual can play it off and, say, yeah, I know where I am. I was just messing with you, that kind of thing, and be a bit dismissive. And in their explanation often makes enough sense that you can go, oh yeah, I can see where, he or she's being that way. What you may also see is accessory muscle use. So this would be consistent with dyspnea and increased work of breathing. Commonly, you can be short of breath and just be using your diaphragm still to breathe. But as the work of breathing goes up, you may see patients using the intercostal muscles along with the sternocleidomastoids of the neck as they're really straining to breathe, using every muscle that they can to try to bring oxygen into the body. So as far as management goes, we want to, in a priority fashion, we are going to immediately begin to prioritize oxygenation and ventilation. Remember the basic principles of airway, breathing, and circulation. So we want to definitely make sure that their airway is patent. Can they clear those secretions? Do they have good airways? Do they need a bronchodilator? Back to the wheezes, right? Those things bring concern. And obviously, if they're sounding stridorous, we definitely want to address that. That's airway. And then definitely be looking next at oxygenation and ventilation. I know it's not listed first, but it is priority here. The reason I have identify organism here listed first is to emphasize the mantra I've been putting in front of you guys so far this semester: treat the problem, manage the symptoms. If someone presents with what is consistent with pneumonia and we ascertain that they have pneumonia and make some kind of determination that's what we're dealing with, we can clear their airway, we can provide oxygen, we can provide ventilation, and yes, we manage those conditions. However, if we're not identifying the organism and attacking the organism in some form or fashion, then we're not treating the problem. We're just managing around it. So organism identification is critical. Now, the first thing you're going to see attempted is a sputum culture. This is fantastic if it can be done and done well. There are a couple of issues with sputum culture, and that is, one, the patient's got to be able to cough something up. They've got to have a productive sputum, and it's got to be sufficient for testing in the lab in order to take that bacteria, put it on a petri dish, put it on a slide, do a gram stain on that, perform an acid-fast bacterial test it for whether it's anaerobe or aerobic, and then specifically identify the organism because we're going to treat a fungal infection differently than we're going to treat a viral infection. And both of those are going to be treated differently than a bacterial infection. Now, what you will commonly see is, based on the history and physical and the overall assessment of the patient, the providers are going to be determining an initial antimicrobial therapy. And you can reference Bruner here, pages 593 to 595 on this, but they'll be looking for an antimicrobial therapy initially that's broad enough in spectrum to cover what they're hearing from the patient that reinforces where they suspect this infection came from. So, for example, cared for a patient years ago who went down to Alabama to assist his brother in preparing the house for one of the hurricanes that was coming. So they were up in the attic pulling down hurricane shutters that were meant to cover the windows. And they'd been up there for some time, at least a year or more. I'd been up there for quite some time. And you can imagine they could have easily have been wet, moist, or damp when they put them up there. They're up in the attic, they're sitting there for a long time, and attics are not pristine. So when this guy presented to the hospital with a pneumonia, he was very ill. When they presented to the hospital with pneumonia, then in that case, the physicians chose a antimicrobial regimen that included bacteria, fungus, and virus, because he very well could have been around his brother who had some viral infection of which he was unaware. He could have also encountered a bacteria or fungus from these panels, these shutters that were up in the attic, and he could have encountered that whatever the condition that caused him to have some issues. There could be normal flora bacteria that took the opportunity of this initial fungal problem to precipitate another concomitant bacterial infection. So they used multiple agents in a very broad spectrum until they could identify a specific culprit in his case. So that's what I mean by starting broad. If you think about, if you're familiar with a gun, like a shotgun versus a rifle, a shotgun has a distribution of pellets that covers a large area, whereas a rifle has a small lead or metal head that is the bullet itself, which makes a very small puncture relative to a shotgun. So small coverage versus broad coverage. And that determination, identifying the organism, also determines our containment strategy. So if this is normal flora for the patient, then there may not be a reason to do anything other than universal precautions. If it is methicillin-resistant Staph aureus, then we definitely need to be gowning and gloving, not because Staph aureus is going to be a bad infection for another patient, but another patient may not have that mutation and may not need to develop it by being exposed to this patient's methicillin-resistant Staph aureus. So you can see how that guides our containment strategies. If the patient, so in addition to these main concerns that apply to all patients, if the patient is diabetic, we definitely have to manage glucose, because when the glucose is out of control, and by out of control in the hospital, generally we're referring to 180 or greater. When the glucose is out of control, not well managed, then we will increase that patient's susceptibility to perpetuating this infection or reducing their capacity to fight this infection. So both of those things are issues with high glucoses. And generally in the hospital, we're going to be trying to shoot for a normal range for patients somewhere between 80 and 140. We don't expect them to be pristine like everybody else in 120 range, but we're going to have an aggressive sliding scale between 140 and 180, and definitely working to keep them under 180, shooting for 140 or less, and above 80. We'll talk about that more when we get into diabetes. Hydration is also important. Now, I mentioned this as optimal hydration, not as giving lots of fluid, but as keeping them optimally hydrated. We want the kidneys to have plenty of fluid moving through them, good perfusion to the kidneys, and we want the sputum to not get dry and dehydrated. As the sputum gets drier, it gets thicker, which makes it harder to clear, either by the patient themselves or from us if they're on a ventilator and we're trying to suction. So we have to be conscientious about that. And we may even employ mucolytics to help them clear those secretions. Nutrition becomes a very valuable piece here. One, to make sure we're managing glucose so we're not giving the patient too much glucose if they are diabetic. But even in the non-diabetic population, the body needs fuel. The mitochondria need fuel, and that fuel comes from the processing of fats, carbohydrates, and sugars in order to provide the oxygen and ATP into the Krebs cycle and the electron transport chain, which drives all of these vital processes at the cellular level to fight infection, from the mitochondria to the white blood cells, to the leukocytes. All of those things, the eosinophils, all of them need power to do their work, and that optimal nutrition is going to be the key to that. There may be a variety of ways we approach that nutrition. Pain management becomes important, not just because we don't want people to hurt. In this case, we're using pain management to facilitate coughing and mobility. So if the patient is in so much discomfort that they can't tolerate being turned side to side, that's a problem. We've got to manage that so that if the most they can do is rotate side to side in bed, we've got to make that doable for them. And that may mean a little bit of analgesia. If they're not intubated or intubated, either one, if they're having a pneumonia, we want them to be able to cough. And if they're sore from a motor vehicle accident that perpetuated this, or surgery that led to this, or just the whole process in and of itself leading to this pneumonia, if they're sore in their chest and we want them to cough, if they're sore enough they're not coughing deeply, that's not effective. We need to utilize pain management so that we can get a good cough from them. And that is directly related to the next thing, which is that help assistance in mobilizing secretions. So hydration and pain management facilitate that mobilization of secretions and ultimately the mobilization of the patient. So once we're at a place where we can exceed turning in bed, then we definitely want them up and moving. And if that's just walking to a chair or standing and turning to a chair, walking in the hallways, all of those things facilitate improvement and recovery from pneumonia. And TCDB, you're going to see this, you've seen it before, you see it all over the place. It's a staple of pulmonary care for any patient, regardless of what they're admitted, and that's turn, cough, deep breathe. So we want deep breaths, we want coughing and turning on all patients that come into the hospital. Not only does it help with the recovery of pneumonia, it also helps with patients who don't have it, preventing them from developing it. We don't want portions of the lung to become atelectatic and unused and then harbor the potential for pneumonia. So treatment, as I've kind of alluded to here, obviously oxygen therapy is going to be a part of that. With our patients who are chronic CO2 retainers, as we've discussed prior to all this, we're going to be cautious with our oxygen therapy. We want optimal oxygenation. We don't want excessive oxygenation. We don't want the formation of free radicals and oxidative complications as a result of too much oxygen. In the case of our emphysema patients, we're going to be titrating their oxygen to keep them somewhere between 88, maybe 94, 92 on their oxygen saturations. We're not going to be trying to drive them up to the 9800s because we don't want to complicate the emphysema as they're trying to recover from pneumonia. Antimicrobial therapy, as we've discussed, determined by culture, history and physical, and by culture, I mean culture of the sputum or some other opportunity. And there are times in which we may have to do a bronchoscopy in order to get in there and get a good enough specimen in order to determine the culture, what's going on there. Corticosteroids to help mitigate the inflammatory process. In some of these cases, as you know, steroids can suppress the immune response, but in some of these cases, the inflammatory aspect of the immune response is basically hijacked and is excessive in response to the pneumonia. So we may need to mitigate that inflammatory response in order for the patient's tissues to heal and the antibiotics to be able to be effective. We don't place patients with pneumonia on corticosteroids and not antibiotics. They can be on antibiotics without steroids, but we are not going to put them on steroids without antibiotics unless we know there's some way they're going to be able to fight that infection. So bronchodilators are going to be perhaps a component of this if the patient needs assistance getting those airways open in order to optimize ventilation. So I mentioned oxygenation earlier. Both the corticosteroids and bronchodilators assist in the ventilatory process. So the corticosteroids will decrease the inflammation. The bronchodilators help open the airways so we can get a more optimal ventilation, which may augment our efforts to oxygenate the patient. Expectorants or mucolytics may be a part of this. That obviously depends on the patient's hydration level, the thickness of the secretions. Someone, for example, with cystic fibrosis may have this propensity towards thicker secretions. So even though they're adequately hydrated, we may need to add a mucolytic or an expectorant in a population like that. Hydration, as I mentioned before, is going to be an important element. And then supportive care. Now, what I mean by supportive care here is care for the patient that rises to support biologic functions to help them combat the infection. So this is where things can get quite complicated and intricate. Often patients who need aggressive supportive care end up in ICU. This may mean supportive care in that they're not capable to go home and take care of themselves. So that could be a long-term acute care or a skilled nursing facility. But supportive care, that to say supportive care has a broad scope of what's entailed. Supportive care can be things like a mechanical ventilator, vasopressor drugs such as norepinephrine, phenylephrine, or vasopressin. All of those drugs can be drugs that are used to support the blood pressure if the pneumonia is severe enough and causing hemodynamic compromise. That supportive care could also take the form of dialysis. If the patient's kidneys are not functioning in the context of the infection, then we may have to do dialysis to support them through this process. Could also take the form of non-invasive ventilation. We've already discussed BiPAP or non-invasive ventilation. So perhaps we need to provide oxygen in a more aggressive way than just a mask or a nasal cannula. So we provide non-invasive ventilation as a bridge to avoid intubation. Now, the last thing here that I want to discuss in this video, and then we'll pick up from here with the next one, is vaccinations. There are currently two types of vaccines out there that address a different group or cluster of pneumococcal pneumonias. And there's Pneumovax and Prevnar. As you can see here, Pneumovax addresses 13 different variant species of pneumococcal pneumonias, and the Prevnar 13 different variant species of pneumococcal pneumonia. So I can't underemphasize enough the importance of vaccinations. If you have any kind of susceptibility, if an individual patient is on medications that predispose them to pneumonias, if they have medical conditions that predispose them to pneumonias, why would you not take a vaccine that's demonstrated safety and efficacy in a broad scope of population to help prevent the even development of a pneumonia? So vaccines have a huge role in mitigating a large number of the pneumonia species that are out there. So we'll stop here and we'll pick up from here in the next video.